The goals of ambulatory anesthesia explains its popularity. The goal is to provide patients with safe surgery as minimally disruptive to their home life as possible and to allow them an early return to function. We also want to decrease healthcare costs by improving efficiency, and that's primarily by avoiding hospitalization. Looking at the organization of ambulatory surgery centers, there are 4 different models. There's a hospital integrated version. The patients are admitted through separate areas in the hospital that only handles the outpatients, but the surgeries are usually done in the same operating room than inpatients. Sometimes they may have separated or joint PACUs for phase 1 recovery, and outpatients are transferred to separate phase 2 recovery areas. The advantage of this model is that it's very convenient for surgeons because they can cover the ambulatory and the hospitalized patients at the same day, sometimes even during the same time. It also provides a very simple staffing model and facility space utilization. The disadvantage of this model is that it's pretty much the same for the patients, inpatient and outpatient alike. It usually ends up in the same billing, therefore minimal cost savings and efficiency, and it's not really convenient for the patient. A modification of this model is the hospital dedicated model. It's similar to the hospital integrated version, but there are specific ORs set aside for the ambulatory surgery procedures. So therefore the OR staff may be completely separated for the ambulatory surgeries and for the inpatient surgery, or it also can be integrated. Same thing for the PACU, may be integrated or separated. Advantage of the hospital dedicated model is that the staff can be managed separately, therefore it's a little more efficient, but has the same disadvantages. It's not convenient for the patient and also not really offering the maximum savings for the system. A different approach now is having freestanding ambulatory surgery centers. Some of them can be hospital connected or completely a freestanding isolated facility. So for the freestanding hospital connected surgery center, what it means has a completely different admission function or function PACU and discharge area, but it's connected to the hospital. So the facility can take advantage for all the efficiencies, but still maintaining the possibility of staff sharing and equipment sharing if needed. It's convenient for the patient, but it's not as convenient for the surgeon. So the patient flow is possible between the facilities, but the surgeon can only operate at one side, only be present at one facility. The freestanding isolated surgical center from the hospital, it's getting more and more common. And it can be even owned by a small group or single physician. Therefore, it's naturally controlled by the owner, and the governance depends on the ownership. The freestanding surgery center must have a medical director and also should have a director of nursing to make day-to-day decisions. With proper planning, coordination of resources, coordination of all personnel, that includes nursing, anesthesia, surgeon, and auxiliary staffing, it is an efficient patient flow and procedure flow, yielding high patient satisfaction rates, high staff satisfaction rate, provides safe patient care, and also is efficient, so therefore reducing the healthcare costs. But to keep in mind, freestanding facilities do not have a blood bank. They cannot give any blood products. They cannot provide overnight stays, so the procedure must be done on outpatient basis. But there's no limit on surgical time or recovery time. The patient has to be home ready within a reasonable amount of time after the surgery. Office-based outpatient surgery is an important subset of ambulatory procedures. In the ballpark of 8 to 10 million of surgical procedures are done now in an office-based setting per year here in the US. There is no standard classification system for office-based surgery. Many states divide them in those three categories based on the anesthetic technique. Level 1 means minimal surgical procedure requiring topical, local, or infiltration block and only minimal oral sedation. A level 2 procedure would be minor or major surgical procedure with oral or IV sedation during which analgesic or dissociative drugs are used. And a level 3 would be any procedure that requires major conduction block, general anesthesia, or deep sedation during which an anesthesia provider is supporting body function. Based on a 2001 ASA analysis of the close claim in the data bank showed that office-based surgery had a higher severity of injuries, and that was in the respiratory, cardiovascular, or equipment related. 46% of those close claims deemed preventable compared to 18% of ambulatory surgery claims. However, there was a more recent analysis in 2014 by Shapiro, was a larger data set, but still retrospective. And Shapiro found that when offices are accredited and proceduralists are board certified, actually the care is comparable to hospital and ambulatory centers when it's provided in the office. Based on that data, many states, not all, but many states require licensure for office-based surgery centers. The minimal standard of care is that the surgeon should not perform procedures in the office when he does not have privileges to do them at a hospital. Officers should have certification from the appropriate organization if they perform cases under MAC or general anesthesia. And they do have to have a medical director to ensure and implement policies. There are major differences between ambulatory surgery centers and office-based surgical practices. And their main differences are the certification and the licensure requirements. Ambulatory surgery centers are subject to state and local licensures in the institutions listed here. JCO, CMS, and AAASF are the centers accrediting and licensing the ambulatory surgery centers. Office-based, as I said previously, it's state dependent, but certification can be given by those three centers listed. Probably one of the most important aspects for ambulatory surgery is the patient selection. We need to assess our patient's suitability for outpatient surgery based on other conditions and their physical status optimized. Do we have proper equipment and staffing at the center? And to ensure that this patient is an appropriate candidate for this type of surgery in this type of facility. The preoperative assessment process of this patient in the pre-op clinic, which can be performed in person or over phone screening, has to include full review of HMP to assess the need for other studies, either laboratory studies or other tests, and if a referral is needed to consultants if we need further input. Main difference in ambulatory surgery in the pre-op process is that this patient needs to be able to return home on the day of surgery. Historically speaking, all patients in the ASA 1 or 2 category were standard for acceptability for outpatient surgery. However, this restriction has been drastically changed. Most centers will accept ASA 3s and 4 if they are stable, compensated to the illness, and that the nature of their disease does not impact their ability to return to home life after the surgery on the day of surgery. Now we're going to go through certain high-yield topics in the ITE for patient selection for ambulatory surgery. Age. Below 60 weeks gestation age, and especially if they're born prematurely, there's a high risk of post-anesthesia apnea. The risk can be as high as 25%. So therefore, those patients should not be cared for in an outpatient setting. From a practical point of view, so 60 weeks post-conception or 6 months old, that is an age group where you really have to reconsider. On the other extreme, elderly patients, there really is no arbitrary limit. Really has to be done based on case by case and based on patients' comorbidities. Actually, for elderly patients, there may be an advantage of performing surgery in an ambulatory setting because there's less postoperative cognitive dysfunction, presumably due to the multimodal short-acting anesthetic approach and the limit time from removal from the home environment. So therefore, allowing them to return more to the used environment. Patients with COPD technically have an increased risk of postoperative pulmonary complications, but they're usually easy to treat, rarely leading to unplanned admissions or morbidity. So therefore, the rule of thumb is a patient with COPD is candidate for ambulatory surgery as long as they can perform their normal daily activities and they are not oxygen dependent. Patients with asthma, it is a reactive airway disease, most of the time asymptomatic, but patients are still at higher risk for postoperative events compared to normal patients. But also here, those events are usually easily be treatable. The disease is more prevalent in the pediatric population. Patients with asthma are considered candidate for ambulatory surgery if they present, even if they present with wheezing, if the wheezing clears with routine clinical management. It would be an alveolar inhalation or inhaled steroids. If the wheezing persists after routine management, those patients should not be electively anesthetized in ambulatory surgical setting. Patients with upper respiratory tract infections, also very common in the pediatric population, but also in the adult population. The ballpark here is upper respiratory tract infection, more than 2 to 4 weeks. Previously, and symptoms have resolved, those patients are usually candidate for ambulatory surgical procedures. However, since I said very common in the pediatric population, especially in the pediatric ENT population, we have to make a lot of judgment here. Okay. Patients are not candidate for ambulatory surgeries if they present with active productive cough, fever, lethargia, so obviously kind of like having an acute process going on. If they had a recent upper respiratory tract infection within 2 to 4 weeks and the symptoms have resolved, the risk of laryngospasm is still elevated 2 to 20% depending on which study you believe. But in all studies, the issues are generally treatable without serious complications and the unplanned admission risk is low. Patients in the pediatric ENT population, they may be never long enough symptom-free. So here, we loosen it up and say it's acceptable to proceed with a patient after a URI has symptoms are minimal or have resolved. Patients with coronary artery disease are candidates for ambulatory surgery if they're stable and have adequately treated coronary artery disease. Based on large-scale retrospective clinical studies, the risk of MACE and MI or other serious complications is very low. We have to continue the beta blockade and the medical management, though, throughout the perioperative time. Patients with drug-eluting stents in antiplatelet therapy, especially with dual agents, may have to wait until they're after dual agent therapy Waiting period is very much in flux. Currently, we are saying like 6 months post stent placement for elective surgery. And we should seek cardiology input to decide when the patient is optimal for the surgical procedure. In an outpatient setting, it is best to combine the patient's clinical risk factors and surgical risk factors to determine the risk for major adverse cardiac events. Patients with other cardiac diseases like congestive heart failure or aortic stenosis. The functional status needs to be aligned with the patient care goals. Obviously, if there's active, decompensated congestive heart failure symptoms in place, this is a contraindication for ambulatory surgery, and the patient should be optimized before we're proceeding. CHF has been shown to be an independent predictor for postoperative adverse cardiac events. However, if adequate functional status for the planned surgery aligns with discharge to home on day of surgery, the patient still may be a candidate. Aortic stenosis. If aortic stenosis is severe, which, let's say like less than 1 centimeter square, the patient is at higher risk for postoperative cardiac and pulmonary complication, so may not be a good candidate for outpatient surgery, especially if it's performed in a freestanding setting. Proper preoperative evaluation in patients with cardiac rhythm management devices is required, and it should include the type of device, the magnet response, and ensuring proper working and battery life. In pacemaker, that means the device should be checked in the last 12 months. With AICDs, the device should have been checked in the last 6 months. You need to know the underlying rhythm and if a patient is pacer dependent, and that data should be provided to you from the preoperative assessment process. Based on the surgery, if the surgical site is less than 15 centimeters from the device, based on monopolar versus bipolar cautery, also you need to have recommendations if the device needs to be disabled and reprogrammed. That's the same thing for ambulatory surgery patients than for inpatient or admission post-surgery kind of patient. The patient is suitable for ambulatory surgery if all that has been indicating a stable situation, but there still needs to be an individual present who, or not necessarily present, but available to reprogram and manage the device in the surgery center. Now, so how about patients with malignant hypothermia? Malignant hypothermia is just as likely to occur in a healthy patient in an ambulatory surgery center as in a medical complex inpatient. Overall, there's a low incidence of malignant hypothermia, and most of them we have a patient history or family history who can guide us in a leading direction. Malignant hypothermia patients can safely undergo outpatient surgery center if they're using non-triggering anesthesia technique, and they also can be discharged on the day of surgery if the anesthetic has been uneventful. The requirements are listed here. Any anesthetizing location, we have to have dantrolene available. We have to be able to perform a non-triggering anesthesia technique. There is no point in giving prophylactic dantrolene. You have to have a properly prepared anesthesia machine. While it's still unclear how long a volatile anesthetic may be present if you don't have an MIH naive or volatile naive machine available. The charcoal filters are seen as a reliable tool to exclude the contact of the patient with volatile anesthetic. The postoperative discharge time does not need to be prolonged. While there has been suggestion in the past to observe patients for 4 hours after surgery, this is really not necessary based on large cohort studies. There is MHouse and Samba combined have developed an MH algorithm, and There also has to be a transfer protocol in place with the hospital and in a transport carrier if we are talking about a isolated freestanding surgery center. Patients with diabetes may present to you for ambulatory surgery, and most of them are candidates for ambulatory surgery or office-based surgery. But of note, if they present with poorly controlled diabetes, hemoglobin A1C is probably most commonly used to determine that. The patient is not optimized and should be referred to a primary care physician or endocrinology for evaluation and optimization. And it's more for, the whole long-standing perioperative complication associated with poorly controlled diabetes. Coming back to the anesthesiologist judgment, who is a candidate and who is not, there really is no cutoff point for postponement. You just have to decide if you can obtain control in an outpatient setting. If insulin is given, especially to an insulin-naive patient, there is the risk of hypoglycemia, which can be actually more dangerous than hyperglycemia. So if control is obtained with short-acting insulin and it's initiated in the ambulatory surgery center, the patient needs to be observed and educated about the possible consequences, which hypoglycemia can occur 3 to 4 hours after the last insulin dose, just to keep that in mind. Obesity, also a very common cohort which will be presented to you for ambulatory surgery. There's an extra level of complexity, not only because of the body weight, but also the more or less diagnosed comorbidities and the difficult airway management. But the surgery center has to really look at the bigger picture from equipment needs, staffing needs, in addition to comorbidities and difficult airway management. Based on large-scale studies, BMI 30 to 50 really does not appear to be an increased risk for perioperative complications as long as comorbidities are minimal or optimized. However, due to equipment needs and staffing needs, most OR beds exceed their weight limit with a BMI above 50. So most centers probably will come up with their own threshold, which patients are acceptable and which one are not. Patients with obstructive sleep apnea and other candidates for ambulatory surgery. Also, this is a topic ABA, ITE usually dedicates a few questions towards. Obstructive sleep apnea is mostly undiagnosed and therefore untreated, even when patients present to you as surgical candidates for ambulatory surgery setting. SAMBA recommends that all patients are screened with this stop-bang questionnaire, which included here in this slide. So we ask about snoring, daytime tiredness, observed apnea, high blood pressure, if the BMI is above 35, age above 50, neck circumference above 40 centimeters, which is roughly 16 inches, and if gender, male gender. And then based on this, you assign risk categories, 0 to 2, low risk, 5 and above, high risk. And this stop-bang questionnaire actually has a very low false negative rate, almost 0%, and less than 10% false positive rate to identify patients with a moderate obstructive sleep apnea. So by only asking those few questions, you can screen for it. So even if you presume that your patient, based on this questionnaire, has sleep apnea, those patients still may be candidates for ambulatory surgery as long as the comorbidities are optimized and pain management can be provided primarily on non-opiate base. In the recovery room, you should observe for excessive sedation, hypoxemia, before discharging home to an unmonitored setting. Very important part of making your ambulatory surgery center a success is patient education. And it's not only to educate them about the surgical process, but really about the whole experience, including logistics, what time they need to show up, where you want them to park, what to bring from clothes and every other requirements. And also like to include that needs to be a responsible person with them who can get them home. You need to set the expectations, what going home means, what kind of assistance they will need at home, and for how long, to reduce the amount of readmission just needed to they don't have the support system at home. Then the NPO guidelines, also here we all have personal observed in our patient care areas how misunderstood NPO can be and how what damage it can cause. It's not only for food intake and liquid intake, from excess deprivation to showing up not being NPO, but also what medications to take and what not to take. So there needs to be proper instructions in written and verbal form available to your patient cohort. So now let's talk about the postoperative care and what's different in ambulatory setting. So what I'm presenting here, that is the same for inpatients and ambulatory patients. Okay, there are those 5 categories in the ASA standard for post-op care, which all need to be met. Okay, the anesthesiologist is responsible for recovery and discharge from the PACU and in an ambulatory surgery setting for the discharge to home. And the only monitoring mandate by the ASA standard is the quantitative assessment of oxygenation. There are several PACU scoring systems, how we can assess that our patient is recovered from the anesthetic influences, as you see here in our slide. And the most important one probably is the modified Aldrich score, which we're using for fast track criteria, which we'll talk in a second. The recovery room process is separated in several phases. Okay, phase 1 is the early recovery. It begins with the cessation of the intraoperative anesthetic care and ends with the recovery of vital reflexes. Then phase 2 is the immediate recovery, so from the recovery of the vital reflexes to now being home ready. That usually completes the process we see, but then phase 3, and that's the full return to the preoperative physiological functions, which let's name it street ready, that occurs usually outside of our surgical setting. So in ambulatory care, the challenge is to minimize the time spent in phase 1 and phase 2 without the undue risk of readmission. Fast tracking, which either bypassing or shortening the phase 1, has shown to reduce the time to discharge, but it also has shown that it requires actually more nursing intervention, especially in phase 2, to get the patient home ready. So it cuts down on time, but it doesn't cut down on manpower. The fast tracking criteria, and that's why I showed you in the previous slide, the modified Aldrich score. You want to have 12 and higher with no individual scores of 0. The Aldrich scores looks at consciousness, physical activity, hemodynamic stability, respiratory stability, oxygen saturation, and then the post-op pain level and the post-op emesis symptoms. So 7 different categories, so a maximum of 14. You cannot have a 0, and you have to be 12 or higher to meet the fast track criteria. The most common problems are pain control and PONV. Just want to point out there are no requirements to void, unless it's surgically indicated, with some urological or gynecological procedures that may be a requirement from the surgical aspect. And there's also no requirement to tolerate intake, PO intake. But we need to instruct the patient if there are difficulties with voiding or tolerating PO intake. We need to set the expectation. When you go home, that's what you should be doing. And if this is not happening, they need to have contact information and some tools what to do if they can void and they can tolerate PO intake. So last but not least, what are our delays of discharge to home? Also an area very commonly asked during the ITE. The most common problem, PONV. So therefore, Samba actually has set up those criteria, and there are multiple algorithms. I'm sure you're familiar with some of you've seen before. We have one. Okay, so the requirement is like identify patients at risk for PONV, reduce the baseline risk factors, give prophylaxis. Okay, minimum of that's depending on the risk score. Minimum of 1 or 2 agents should be given. Okay. Then combine prophylaxis with other interventions or therapy in high-risk patients. Treat if there was no prophylaxis given or the prophylaxis failed. It should be a multimodal intervention, and it should be guided by a PONV policy. That also applies for ambulatory patients. The other common cause for discharge delays or unwanted hospital admissions is pain. Okay, so therefore, in ambulatory surgery, we really encourage generous use of local anesthesia infiltration by the surgeon or the use of peripheral nerve blocks. We also encourage a non-opiate-based analgesia approach. Maximize NSAIDs, acetaminophen, gabapentin, or the alpha-2 agonist dexmedetomidine or clonidine. Also here should be a multimodal approach, should be a cooperative patient. And also like the continuous peripheral nerve block catheters with a continuous device also have facilitated a lot of procedures in comfort level for those patients. Unanticipated admissions is really the one thing we want to avoid, okay, because we're losing all the benefits of our ambulatory surgery centers and free and office-based surgery. Based on national data, the accepted range is 0.28 to 1.5%, depending on what kind of surgeries you do. And the readmission rate within 30 days of discharge from ambulatory surgery center should be less than 3%. The most common causes for this: uncontrolled pain, surgical complications that includes bleeding, medical complications, so exacerbation of CHF, COPD, etc. And then anesthesia-related complication, that's in that category is PONV. Every center has to track the data and analyze the data and see where they can optimize the process if we fall out of that accepted range. It's part of their certification and licensing process. This concludes my review on ITE keywords for ambulatory surgery. I want to finish with those 2 pictures from our Center of Advanced Surgery, our ambulatory surgery center here, connected to the hospital, and then our isolated freestanding surgical center, our Lexington Surgery Center here on Turfland. Thank you very much.